Okay, so we want to know what is happening with, let me just hide that. What is happening with COVID in pregnancy right now? Next slide. Okay, so this is the number of cases per day. The blue line and the green line just gives you the moving average for every 4 days. And the red little bars below are suspected cases, but not confirmed. If you look at the end, which is 1,871, then we're almost back to where we were last July the 4th. Next slide. So COVID is on the increase. So COVID hospitalizations, I got this off of Conway Medical Center. They had 17 people with COVID. I know 9 in the ICU, I think 3 intubated, and 100% of them were not vaccinated. Next slide. So, this phenomenon of COVID showing up in unvaccinated people is not only a local phenomenon in like Horry County. It's true at MUSC, it's true at Prisma, it is true in Vegas, which was one of our first hot spots. This graph shows the 8 hospitals in Las Vegas, and the lowest one was 91%, and 3 of them were with 100% vaccinated. I just got a question. Is there a comparative number with vaccinated people? So if you look on the left, there are 3 hospitals, and 100% of the people who were in the hospital with COVID did not have the vaccine. And the lowest hospital was 91% vaccinated. There was an Israeli study that came out last week that said that the vaccination, they looked at people who had had the Pfizer vaccination, and it was about 39% protective of COVID. And we'll get into that in a minute. So next slide. No, you did backwards.
Other way.
Yeah. Still going backwards.
There you go. Yeah. Okay. Good.
So we all recognize this graph. The blue line is the placebo, and the red line is the Pfizer vaccination. Okay. There are similar data from Moderna, but people took it to mean that this was a prevention of COVID, but the outcomes were never prevention of COVID, because in order to do that, it would have been a much more labor-intensive study, and they would have had to test 20,000 people like every 3 or 4 days. And so Pfizer's outcome was the prevention of symptomatic infections. So if you felt like you had a symptom of COVID, you went in and got tested, and the blue line are the people who were positive, and the red line was people who were not positive. Were vaccinated and were positive. So basically, the Pfizer endpoints was symptomatic infection. Moderna's endpoints were much different than Kaiser, but the graph looked very similar. And that was, they looked at moderate to severe illness, And we are going to look at the definitions of that in this talk. So again, the vaccination wasn't the prevention of the infection. It was prevention of either moderate to severe illness or symptomatic infections. Next slide. So the best prevention and treatment of COVID is the vaccine. Next slide. So both SMFM and ACOG came out last Friday and said every pregnant woman should be offered the vaccination. And we could offer any of the three. And if they start asking us questions, one of the things that the CDC has done is set up a vaccination registry. Now, this was published in the New England Journal in February or March, where it showed that the vaccination safe pregnancy registry, overall, it had very similar rates as to the general population in diabetes, hypertensive disease, eclampsia, and growth restriction. Next paragraph. Next slide, Richard. And the neonatal outcomes, preterm birth was the same, congenital anomalies were the same, small for gestational age was the same, and essentially neonatal deaths were the same as the general population. And so that the CDC extrapolated that the vaccination was safe in pregnancy. And since the Delta variant came into our population, we have been recommending that women get vaccinated. But as of Friday, every OB in the United States should be recommending vaccinations in pregnancy. Next slide. So if, you can send a patient to CVS to get the vaccination. And, sometimes like from a dentist, we'll get, they'll ask us to write an approval for lidocaine or whatever. But a pregnant woman does not need approval, okay? And it can be given in a non-OB setting, like the health department, CVS, Walgreens, whatever. And OB counseling is not required prior to the vaccination. If a woman walks into CVS, then she should be able to get vaccinated, even if she didn't see her OB and him or her did not counsel them. But in our office, I would highly recommend that we document our recommendations. Like, we recommended the COVID vaccine, told the patient where to get, told her how to locate it and get it, and she plans to or she refuses. And COVID, we're trying to get it into our clinic so we can administer it with other vaccinations. And women under 50 can get any of the three vaccinations. The two that you've heard the most news about is Pfizer and Moderna. And both of those are a two-step vaccination. And then there's Johnson & Johnson, but there were 5 women who had thrombosis with thrombocytopenia syndrome. There were evidence of thrombosis in their sinuses and in the brain. And this is a known phenomenon. And both SMFM and ACOG said this is a very, very rare occurrence. And therefore, Johnson & Johnson is just as good as the other vaccines, and that is just a one-shot vaccine. Next slide. So we all know the COVID symptoms very well. Fever, cough, shortness of breath. And it doesn't matter if the patient has been vaccinated or not. If they come in complaining of COVID symptoms, they should be tested. Now, sore throat, and I've read, but I haven't, I mean, this is like a news article and not scientific, that congestion or runny nose and sore throat is more common in people who have the vaccination but then get COVID. Next slide. So the emergency COVID symptoms is somebody calls trouble breathing, pain in their chest, new confusion or inability to stay awake. Then they need to go to the ER or call 911 to go there. Next slide. So the test is going to come back positive or negative. I'm from Aner, and so when my friends in Aner get something, they keep sending me messages via text, via Facebook. Do I know if I got the Delta strain or not? The answer is the COVID test that we use comes back either positive or negative, and it does not give us the strain. This requires a more expensive test that requires genotyping. And other countries are actually better at genotyping their viruses and stuff than we are. Like England was the first one to notice that there was the Delta variant because they were genotyping more than the United States. Next slide. So there's the classification of COVID. The first one is asymptomatic infections. And this is when you go in and say, my grandpa has COVID. I stayed with him for 3 days. Do you mind testing me? So mild is sinusitis, sore throat, loss of smell or taste. Moderate is they have a significant cough, temperature, shortness of breath with exertion, but their O2 sats are greater than 94%. Severe is when there's pneumonia, there's shortness of breath with, this should say without exertion, okay? And O2 sat less than 94%. And critical is when there's respiratory failure, sepsis, or multiple organ failure. And I put a little asterisk because we want to keep the oxygen saturation in pregnancy greater than or equal to 95% because we have a baby on board that is requiring oxygen is using the mother for its oxygen. Okay, next slide. So let's talk about what happens when they test positive. Now, this monoclonal antibodies is not for asymptomatic people, okay? They need to have symptoms, okay? So we have known that the monoclonal antibody infusion is okay for anybody 65 or greater. Medicare was one of the first payers that said we will pay for the monoclonal antibody. So the new The new infusion guidelines say if you're 18 to 64, if you have obesity, chronic renal disease or diabetes, immunosuppression, including sickle cell disease, or immunosuppression treatment, and it has to be ongoing, cardiovascular disease or hypertension, chronic lung disease such as COPD and asthma. And there is now pregnancy as a category, and race and ethnicity, non-white, and anybody who's non-white and or Hispanic, okay? So these individuals should be eligible for the monoclonal antibody. So I'm just going to assume that I have a medical student on this phone call, and I'm going to tell you, you know, when we are exposed to COVID, we make antibodies against COVID. And so early on, we were doing serum from people who had had COVID, and we were using that as an antibody infusion in the very sick individuals. But probably the first time you heard about monoclonal antibody infusion was when President Trump actually got COVID. Now, the only difference between monoclonal antibody, it's mono is one, cloned, you know, they clone the antibody, and so the infusion is very, very rich in COVID antibody, because it was made one antibody was cloned. Okay, next slide. So again, the inclusion criteria are all patients must reside in one of the counties noted. This is actually from one of MUSC's websites, so you can actually ignore that. But if they have COVID symptom onset less than 10 days from an infusion appointment opportunity, and if they're 18 to 54 with one criteria, 18 to 64 with one criteria, or no additional medical screening is needed for the patients over 65. The exclusion criteria is a previously positive COVID test greater than 10 days ago, okay? And the onset more than 10 days from when the infusion can be scheduled. So if I am at 9 days out, you are highly unlikely to get an infusion schedule within 48 hours. And they don't run on the weekends, many of these. You have to have symptoms. It's either mild or moderate. You cannot be asymptomatic and just get the test because granddaddy had the disease. You cannot be in the hospital. You're required to be on an outpatient and be able to go to where they have the clinics located. And if you are having moderate disease, okay, and your oxygen requirement is increasing, okay, then you cannot get the infusion. Next paragraph, or next slide. The side effects, nausea, vomiting, diarrhea, the biggest one is anaphylaxis. It's very unusual, but that is the most obviously deadly one. Next slide. So just so you know, if patients ask you information, the infusion takes approximately an hour, and they make you sit in the unit for an hour to make sure there is no anaphylactic reaction. This too is used under emergency authorization. And you know, some people say, well, the vaccine's under emergency operation and I don't want to take it. Well, they gave monoclonal antibody to our president who and there were less than 300 people in our country that had gotten this. So emergency authorization, I say if it's good enough for the president, it is good enough for me. Now this, it says you can receive the COVID vaccine for 90 days. That's a typo, and it's you cannot receive COVID vaccination for 90 days. Next slide. And this is my last slide because I see this as mistakes that are probably the most commonly made. The monoclonal antibody is just being approved for pregnancy recently. So hospitalization, but does not require supplemental oxygen. Okay, there is no, this is from the NIH too. I mean, to put that down here. The panel of experts recommends against the use of dexamethasone or any other corticosteroids. I just talked with one of my family members and they tested positive on Tuesday and their doctor gave them steroids on Wednesday. And there was no problem whatsoever. She was an outpatient. Please don't do this, okay? You only give the patient steroids if they're in the hospital. Now, if they're in the hospital and their O2 sats are 92, 93, then you should give remdesivir, okay? And there isn't great evidence for it. It's B, it's moderate evidence. And you can give dexamethasone plus remdesivir with patients who have increase in supplemental oxygen. And dexamethasone, when you can't get remdesivir, cannot be used. You can use it when remdesivir is not available, essentially. Now, I'm not going to go over the last two categories because by this time, OBGYNs are not taking care of the patient. All right, that's the end.